Ladies and gentlemen, this will be a talk on gestational diabetes. If you haven't already, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can click the link below in the description of this video or on the I button on the upper right hand corner of the video, and that should link you up. Consider just pitching in $1 a month. A little bit goes a long ways and helps keep these videos free. Thank you very much in advance. So there's a couple ways you can have diabetes during pregnancy. The more common way that we run into it in practice and on the test, they'll really want you to know this, is the phenomenon known as gestational diabetes. And that is diabetes that is diagnosed during pregnancy and then subsequently goes away after delivery. There's also the possibility that the woman has diabetes and then gets pregnant, or perhaps she has diabetes and it doesn't go away after delivery, in which case we call that pre-gestational diabetes, and that will be the subject of a different talk. So gestational diabetes is a condition of glucose intolerance with the onset occurring during pregnancy. So the first recognition of the diabetes occurs in pregnancy, and then it goes away after the pregnancy is over. And this affects about 6% of pregnancies in the United States. There's varying, different sources will say different percentages, but 6% is what we believe is the prevalence of gestational diabetes. The problem is a lot of women don't get good prenatal care, and so it may not get diagnosed. And so this number may be a little bit lower than the actual incidence, but this is the estimate that we've come up with. What are the risk factors for gestational diabetes? Now, if you get a question on the USMLE about gestational diabetes, they'll probably give you a very stereotypical case. The USMLE loves stereotypes. You know, they teach you in medical school not to stereotype your patients, but then they give you a test to get your medical license, and it's all full of stereotypes, sometimes even offensive, like every patient with AIDS is a homosexual, right? But gestational diabetes does have some risk factors, and the biggest one is having had gestational diabetes in a previous pregnancy. These women are over 13 times more likely to have gestational diabetes in subsequent pregnancies. Another one, which I didn't add here, but it is a risk factor, is having a macrosomic baby in a previous pregnancy. Now, what's likely the case there? Gestational diabetes that was not diagnosed. Okay, so that is another possibility. An overweight mother. So what is overweight? Anything BMI over 25. That's all the time in the United States, right? We're a fat country. So a lot of women in this country are going to be at increased risk. And then pretty much anybody who's not white. So non-white people have an increased risk. Asians, 2.3 times more likely. Native Americans and Pacific Islanders, 2.1 times more likely. Hispanics and blacks are between 1 and 2 times more likely to develop gestational diabetes. So what's the physiology? Why does this happen? Why do you get quote-unquote diabetes during pregnancy and then it goes away? There's got to be something going on with the physiology of the pregnancy. And in fact, the placenta creates a hormone known as human placental lactogen, or human chorionic somatomamotropin is another another name for that particular hormone. And what that does is it reduces the mother's sensitivity to insulin. And that's a good thing, right? It's a good thing because it means mom's going to take less glucose in, and so there's more glucose in the circulation for the baby. Okay, so baby will be able to pull in sugar more easily. It'll be able to cross the placenta, and there'll be more glucose around. Now, as a consequence to this, the mother, her pancreas is going to respond, and the beta cells in the pancreas, which secrete insulin, will undergo hyperplasia, and that's going to increase her insulin levels. So you have a balance here. So you've got this human placental lactogen, which is secreted by the placenta. The amount is going to go up during pregnancy as the placenta gets bigger. And then the maternal pancreas is going to respond to that by increasing maternal insulin levels. It's thought that gestational diabetes results from an imbalance of these two processes. So what's going on is that you have this human placental lactogen, and it reduces insulin sensitivity, and then the maternal pancreas undergoes hyperplasia, the beta cells undergo hyperplasia, but it's not able to respond to a great enough degree, and so you have an imbalance where you have a reduction in insulin sensitivity and not enough maternal insulin. And so the result of that is there's going to be a higher glucose level in the blood, and consequently there's going to be more glucose that's going to be able to cross the placenta and get to baby, and that's going to result in some of the complications that we see from gestational diabetes. So what do we do for this? Well, yeah, there's all those risk factors, and I suppose once upon a time we thought, well, maybe we'll just go down the list and figure out which women have enough risk factors that we want to test, but we've decided some time ago that we're just going to screen all women because there's such a high risk. I mean, 6% of the population, that's pretty high. And the consequences of undiagnosed gestational diabetes are so high that it's just more worth it to just test everybody. So we universally screen all women for gestational diabetes. When do we do this? We do this after 24 weeks. And the reason we do it after 24 weeks is because the placenta is simply not big enough until 24 weeks to cause gestational diabetes. So if you were to do it at 12 weeks, you would probably have a false negative result. Even though that woman would go on to develop gestational diabetes, the placenta is not big enough to secrete enough human placental lactogen to cause the gestational diabetes. So we wait until the placenta is big enough. So that comes at 24 to 28 weeks, and so usually the mother will have the gestational diabetes screening at her second trimester visit at about 24 to 28 weeks. The test that we do, the screening test, is called the 50-gram 1-hour challenge test. Now, I'll just preface this by saying that some practitioners are doing a 75-gram 2-hour test for all women, and that is both a screening and a diagnostic test, but that's not going to be on the USMLE. That's kind of a newer rogue practice that's being done. But the screening test that is done for all women is a 50-gram 1-hour challenge test. And so all you're doing, she does not have to fast. She comes in, she drinks this little drink. It's kind of like a soda, and she drinks it. It tastes really terrible, but she drinks this, and then after 1 hour, you're going to measure her blood glucose level. And if it's over 130 milligrams per deciliter, that is considered a positive screen. And about 15% of women will have a positive screen. Does this mean she has gestational diabetes? No. But it does mean that we need to do further testing. And what we do at that point, if it's more than 130 milligrams per deciliter, is we get the 100-gram 3-hour oral glucose tolerance test, the OGTT. Now this test, she'll need to come in on a different day because she needs to fast. Okay, so the diagnostic test, she needs to fast. The challenge test, she does not. Okay, so she comes in, she needs to be fasting overnight, and she comes in at 9 in the morning, and we're going to take her glucose level right then and there before we give her this bolus that she drinks. And so we take this fasting blood glucose level. If it's over 95, we consider that a positive result. Does that mean she has gestational diabetes? No. Okay, but we consider that a positive result. Put that in your pocket because we're going to come back to that. If it's over 125, if she has a fasting blood glucose of over 125, not only does she have quote-unquote gestational diabetes, but we diagnose her at this point with overt diabetes. Could either be type 1 or type 2, usually it's type 2, but at this point she has overt diabetes, and we end right there and we say that she is a diabetic woman who is pregnant. Okay, so now you give her the oral glucose, and after 1 hour, you're going to measure her glucose again. If it's over 180 at 1 hour, that is considered a positive result. You're going to measure it again at 2 hours, regardless of whether it's positive or not. Regardless of the level, you're going to do 1 hour, 2 hours, and 3 hours in all of these women. At 2 hours, if it's more than 155 milligrams per deciliter, then that is considered a positive result. And at 3 hours, if it's more than 140 milligrams per deciliter, then that is considered a positive result. Out of all of these, fasting, 1 hour, 2 hour, and 3 hour, you need to have 2 positive values in a single test. And if you have 2 positive values in a single test, you can make the diagnosis of gestational diabetes. Okay, but remember, if the fasting blood glucose is over 125, you don't even need to administer the glucose. Okay, you will diagnose her with overt diabetes. If it's over 95, then that's considered a positive, but you need to have 2 positive values in a single test. On the USMLE, you'll be given all these values of what the upper limit of normal is, so you don't need to memorize these for the test. So this is that 75-gram, 2-hour oral glucose tolerance test I was telling you about. This will not be on the test, but you may see this in practice. All they do is they have the woman fast. They have all women do this same test. They don't bother with the 50 or the 100. They just have all women do this same one. And they need to fast. And so they come in, and you take the fasting level, you then give them the 75-gram, and you take the blood glucose at 1 hour and then at 2 hours. And if any of these are positive, then you consider this woman to have gestational diabetes. Okay, but this will not be on the test. This is sort of a newer approach. The nice thing is you don't have to have her come in a second day. The negative side of it is that you've got all these women now that have to fast, and fasting is kind of a pain in the butt because they have to come in early, otherwise they have to not eat for several hours, and so this can be kind of cumbersome. But some practitioners will do this. This will not be on the test, though. So for management, our initial management for women who have gestational diabetes is to ask them to maintain an ADA, American Diabetic Association diet, which is low in carbohydrates, relatively low in carbohydrates, with emphasis on the complex carbohydrates, but otherwise keeping to a higher fat and higher protein diet. We want to keep her calories around 2,200 calories per day. That's still quite a bit, because if you consider the average American, the average person is recommended to consume 2,000 calories per day. That's the recommendations. You know, that may vary, but 2,200 calories per day. Now remember, mom is eating for 2 people, so it's going to be higher. So we recommend 2,200 calories per day, with 200 to 220 grams of those calories being carbohydrates. We also want her to do home glucose monitoring, and this is the toughest part of the initial management because, again, this is kind of cumbersome. And so we have her measure her blood glucose 4 times a day, once when she wakes up, and then after each of the 3 meals, after breakfast, after lunch, and after dinner. And we have her measure it 1 hour after the meal. What we want, what our target is that the fasting glucose should be beneath 90, and the postprandial, 1 hour postprandial glucose should be beneath 140. As long as it stays under this level, we're good. Okay, so diet and exercise is our initial management, and 85% of women, this will be good enough. Okay, but we need to do diet, exercise, and home glucose monitoring. If this management, this conservative management fails, then and only then do we go on to do medical management. And insulin is the gold standard for medical management. Now, it's been, in the last 5 to 10 years, it's been increasing practice to give hypoglycemic agents, and this is now approved. ACOG is a little bit iffy on it, but this is now approved by some authorities to give oral hypoglycemics. But for the test, insulin is going to be how you manage this because it's the gold standard. It's what we've been doing for a long time, and we know its safety. There's some concern with the hypoglycemics that it may cause birth defects, and we found for the most part that that does not happen. But insulin is what you want to go to on the test, okay? Just a tip from me to you. So insulin's the gold standard. What do we give? We give NPH, our intermediate acting insulin in the morning. That will get her through until dinner time, and then Humalog after dinner, our short acting insulin. Hypoglycemic agents, they give glyburide and metformin, one of these two. Glyburide is probably the safer one if I had to venture a guess, but either of these are good. Okay, metformin or glyburide. So this is what I like to show patients how they should be sort of forming their plate. Half their plate should be vegetables and fruits, non-starchy vegetables, so not potatoes here. We're talking carrots and tomatoes and peppers and stuff like that. A quarter of the plate should be lean proteins, chicken, fish. And then a quarter of the plate should be carbohydrates. So that can be pasta and corn and potatoes and what have you. This is just tips for patients. A lot of them will find this diet to be bland. We like to eat what we like to eat, but you can make this a little bit more palatable by adding things like garlic and lemongrass and ginger and just sort of adjusting it for flavor. Be careful with some of those sauces like barbecue sauce and ketchup. Those have sugar in it, so you have to be careful with those. But things like balsamic vinegar and soy sauce you got to worry about the sodium, but that for the most part is okay in these patients. So some of these sauces, these sauces are fine, but just make sure you tell patients you can use sauce. Make sure that they're aware that ketchup and barbecue sauce, those all have sugar in it. Okay. Make sure that you stress to them that potatoes, sweet potatoes, turnips, those are more starchy, and so those should fall under the carbohydrate category. When we're talking about vegetables, we're talking about mushrooms and carrots and peas and celery and tomatoes and stuff that little kids don't like, but grown-up moms should have some taste for, hopefully. So what do we do beyond this? Well, we need to monitor these patients a little bit more closely than we monitor our average patient because there are certain risks involved, certain complications. So our obstetric management includes, beginning at 32 weeks, we want to do weekly non-stress tests or biophysical profiles. And that's going to be done every week, and that's just surveilling for good fetal status. We want to do a sonography at 34 to 37 weeks, looking at the size of the baby. So remember, anything beyond 4 kilograms is considered a macrosomic infant. Anything beyond 4.5 kilograms is going to be a mandatory cesarean section. And what we're worried about here is we want to make sure that the baby's not too big. Because if the baby is too big, we cannot deliver the baby vaginally because you're going to run the risk of traumatic delivery, you're going to run the risk of Erb's palsy, you're going to run the risk of arrest of labor, and so we want to avoid all that stuff, and so that's why we're doing the OB sonography. We're not so much worried about some of the things that you worry about in pre-existing diabetes, some of those malformations and stuff, which we'll talk about in a little bit, very briefly. If there's good glycemic control, you can schedule a delivery at 39 weeks. Why do we not wait until 40 weeks? Well, because we consider 39 weeks to be a term baby. And if you go to 40 weeks, what we've found is that the risk, you don't really get a whole lot of benefit by going that extra week. And if anything, the baby is going to be too big. So we do a scheduled delivery at 39 weeks if there's good glycemic control. If the glycemic control, however, has been poor, then we can schedule the delivery at 37 to 39 weeks, but we need to first do an amniocentesis to confirm fetal lung maturity. The follow-up is very important, and so at the first postpartum visit, we're going to screen the mother using a 75-gram 2-hour oral glucose tolerance test or a fasting blood glucose level. And we're screening her for overt diabetes in this case, because women with a history of gestational diabetes are 7.4 times more likely to develop type 2 diabetes. And many of these women, their first manifestation of type 2 diabetes is going to be during pregnancy. Why is that? Probably because a lot of these women had type 2 diabetes before the pregnancy, but they weren't being screened because a lot of women don't go in for their annual physicals. They're not being screened for diabetes, but they do go in and they do get all this screening tests and all this care when they're pregnant. And so what this probably meant was not that the type 2 diabetes started during the pregnancy, but that it pre-existed the pregnancy and is just now continued on because this was overt diabetes in the first place. The mother should be screened for type 2 diabetes every year. Okay, so if she has a diagnosis, a past diagnosis of gestational diabetes, she should be checked every year for type 2 diabetes. So fasting blood glucose every year, checking for type 2 diabetes. So this is the rule of 15s. I found this online, and so this is kind of nice. So 15% of women will have a positive 50 gram 1 hour screen. Does this mean they have gestational diabetes? No, it does not. It just means they have a positive screen and we need to do the 100 gram 3 hour oral glucose tolerance test. Of these women, of these 15% of women that have the positive screen, 15% will have the positive 3 hour test and they'll have gestational diabetes. And of these women with gestational diabetes, 15% will go on to require insulin. So the conservative management of diet and exercise will fail. What are the complications? So the complications are, we always think, anytime we have an obstetric disorder, we think of the maternal complications and the fetal complications. So the maternal complications include polyhydramnios, preeclampsia, postpartum hemorrhage, increased C-section risk because of the size of the infant, and infection. So why postpartum hemorrhage? Well, because if the baby is big, the uterus is going to be distended. If the uterus is distended, it's going to take longer for it to contract after delivery, and if it takes longer for it to contract, you're going to lose more blood. So postpartum hemorrhage is a possibility, and you want to be prepared for that. If you have a macrosomic infant that you're delivering, preferably via C-section, but either way, you want to be prepared for this. Diabetic emergencies, as can happen in any diabetic, hypoglycemia, diabetic ketoacidosis, and diabetic coma. The hypoglycemia probably coming from injudicious use of insulin. And then vascular and end organ involvement, more something that we're worried about in our type 1 and type 2 diabetics, not so much the gestational diabetes, because these are things that happen with chronic, long-standing diabetes, not just the gestational diabetes that pokes up during pregnancy and goes away later on. The fetal complications. The number one fetal complication that you need to be worried about with gestational diabetes is macrosomia, big baby. And so what would come out of this? Well, traumatic delivery. You have to use forceps or something like that. That can be damaging to the baby. Shoulder dystocia, big deal. Okay, this can arrest the pregnancy. It can lead to fetal distress and an emergent C-section. Erb's palsy, damage to the brachial plexus. Neonatal complications include hypoglycemia. Why would the baby be hypoglycemic after delivery, after getting all that glucose? Well, you get all that glucose, pancreas is going to mature and enlarge, and so the baby is making all this insulin to deal with all this glucose that's coming in from mom. Now the baby is delivered, no more placenta, no more glucose from mom, but still baby has lots of insulin. And so now the baby's relying on its own glucose, its own digestion, and you still have high levels of insulin. That's going to cause a hypoglycemia. So these babies, it'll be a transient hypoglycemia. The pancreas will eventually respond appropriately by reducing secretion of insulin, but these babies will be transiently hypoglycemic, and this can be a serious matter. This can lead to death, so you have to be very careful with this. Make sure that these babies of diabetic mothers are having their glucose levels checked regularly. And then hyperbilirubinemia is a possibility, but this is, again, something that we see a little bit more frequently in our overt diabetic mothers, type 1, type 2 diabetic mothers. In childhood, children of mothers with diabetes do have an increased risk of obesity, as well as an increased risk of developing type 2 diabetes later in life. Now, some of the complications that we see in overt diabetes, so not the gestational diabetes, but the babies of moms that had diabetes before pregnancy, we don't see in gestational diabetes. And the reason is because gestational diabetes is something that develops towards the second half of pregnancy. It doesn't exist during the first half of pregnancy. And so a lot of those things that are involved with organogenesis, the neural tube, and things like that, they're not affected with gestational diabetes, because remember, it takes time to develop gestational diabetes. The placenta has to get big enough. But with overt diabetes, the problem is there from the get-go. And so it affects all 3 trimesters of pregnancy. And so infants of mothers who have pre-gestational diabetes, diabetes before the pregnancy, they'll be at risk of things like neural tube defects, congenital heart defects, and sacral agenesis. So this is an example of a macrosomic baby here. Big, fat, chunky baby, and this is a normal baby. This baby looks small in comparison to this baby, but this baby is really, truly very big. Now remember, the cutoff for macrosomia is 4 kilograms. So to recap, gestational diabetes develops in the late 2nd and early 3rd trimester and should be screened in all women at 24 to 28 weeks gestation. The initial test is the 50-gram 1-hour challenge, and a positive screen would be more than 130 milligrams per deciliter. The confirmatory test, the test you need to diagnose gestational diabetes, is the 100-gram 3-hour oral glucose tolerance test, and this requires 2 positive values: the fasting over 95, the 1-hour over 180, the 2-hour over 155, or the 3-hour over 140. Remember, if the fasting is beyond 125, then she has overt diabetes. You make the diagnosis of overt diabetes right there. You don't even need to do the oral glucose tolerance test. The management, our initial management, is diet and exercise with home monitoring. If she is not able to maintain euglycemic values, then we administer insulin. She takes insulin every day until delivery. Hypoglycemics like metformin and glyburide have been used, but for the test, insulin is our second-line management for women in whom diet and exercise fail. Women who are on medical management should have non-stress tests or biophysical profiles every week after 32 weeks, and they should then be scheduled for delivery at 39 weeks.